MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Hi, welcome to the MedBix Webcast. This is Raman Annamaraju. I'm the host. I'm privileged to have one of the most important, very well-known doctor from the United States. His name is Dr. Robert Pearl. He's a former CEO of a Kaiser Permanente group, and then he's also a Forbes Contributor for Health. And he's a long list of, he's one of the modern health, one of the top 50 people in the most influencers in the healthcare industry. And one of the things I loved, I met him in person when he released the first book, Mistreated, then in Commonwealth Club. It is a truly total privilege. And then after that, I was following him. He writes a very crisp, clear, one of his writings are very short sentences, very good. And I learned a lot from him in his writing skills. Actually, I have to tell him thank you about that part. Dr. Robert Pearl is a, eminent physician in this country, is a Stanford faculty, and then he writes a new book on ChatGPT AI. That ChatGPT, I was skeptical in the beginning about this, but I changed my mind. I tell you how I changed my mind. Maybe Dr. Robert Pearl is a part of it, but let me bring you to the table, and then Dr. Robert Pearl to the desk, to the main stage. Welcome, Dr. Pearl.
Thank you so much for having me today.
Thank you, sir. Tell us a little bit. I followed you for a long time. Your writings are amazing. And one of the things I loved about one of the things that he said about one article particularly stuck with me, your genetic mutations or genetic confusion between the sickle cell anemia and then muscular sclerosis. He said that, can you explain to us that is what that evolution did that confusion?
The sickle cell disease involves an abnormality in the DNA of patients. We inherit 23 chromosomes from our mother and 23 from our father. And the people who have sickle cell disease, a terrible affliction with organ failure and severe pain, clotting off of blood vessels, happens when both genes are abnormal. And the question I posed to myself was, why should evolution not have eradicated this particular abnormality? And scientists published information demonstrating that although sickle cell disease is quite problematic, far more people have sickle cell traits, one abnormal gene and one normal gene. And in Africa, where many of the Black patients, because of the disease predominantly of Black individuals, that was actually found to be preventive against malaria, which continues to kill millions of people annually around the globe. And I saw the analogy to healthcare, that something that was life-saving in the past becomes life-ending in a different context. And that's what I see right now. The healthcare system that worked well in the 20th century and maybe the 19th and 18th, when we didn't know much of what to do. We didn't face chronic disease as opposed to acute problems like appendicitis or pneumonia. And today, rather than being beneficial, it actually is problematic in the same way that we don't see malaria in the United States. So the sickle cell disease is far more problematic. The sickle cell trait adds little value. And in medicine, the healthcare system, how doctors are organized, how they're paid, the technology they use, the leadership they have, fails to be best for the current time in the United States.
Dr. Pearl actually is a very personal to me. I married I have two children. They're mixed race of African American and Indian. It is that sickle cell. I'm kind of concerned about that. That's why I asked you the question. It is a very particularly black population that came from Africa has that sickle cell disease. That's one of the reason I was fascinated that malaria is the one that prevents malaria, but we don't have that anymore here now. That's a big confusion. Dr. Pearl, I was following you. One of the things you talk about healthcare, health 1.0, health 2.0, and health 3.0. Tell us the evolution. I was involved in that process, indirectly as a non-physician, helping the doctors going through that process. Can you tell us the excitement it brought, the health, all the three things? We'll talk about health 4.0. That's a new book that you wrote about that. But health, all the health 1.0, 2.0, 3.0, what are the changes it brought, good changes, and what are things didn't work out? Could you please elaborate on that things, if you don't mind?
Happy to do so. So you're referencing my new book, which is ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine. By the way, all profits from the book go to Doctors Without Borders, and it's already number one on Amazon's best new books list. So it's hitting a good chord. And the book talks about technology across time. Because again, I'm interested. Why do some technologies take off and do well, and other technologies stumble along? So healthcare 1.0 was the latter half of the 20th century, and we saw massive advances, CT, MRI, ultrasound. We could see into the human body. We had heart-lung bypass machines that would allow hearts to be stopped and restarted. Total joints were being introduced and created. A long litany and list of improvements and advances. Healthcare 1.0 was a major success. We then come to the turn of the century. And what we see is that in healthcare 2.0, it's marked by the introduction of the electronic health record. And I was early in my career, but I remember it well. Tremendous promise, the idea of interoperability, that we'd have information at every point of contact, that we could actually start to address what at that time was the early stages of the chronic disease epidemic that we encounter now today in a much more intense form. We thought this was going to be a great contribution, and it turned out to be a failure. It basically was used predominantly for financial reasons, to billing, claims, justify services to insurers. It was not designed around clinician needs, and it didn't improve clinical outcomes for patients. 3.0 is the era of the internet and telemedicine and text, all the aspects that we expect in our daily life when we use our smartphones, when we use our computers, the ability to book a trip around the world on Expedia, or be able to manage your finances and bank account electronically 24/7. This should have been an era of great convenience for patients, but it wasn't. And today we are only slightly better. And if it was not for the coronavirus pandemic, we might not be any better at all. So the book looks at this question: why was 1.0 successful, 2 and 3 less successful, and then what's going to happen in era 4.0, the era of generative AI?
I remember this health 2.0 where you're saying billing purposes. I used to set up billing systems. They used to ask me, how do I increase the level 3 to level 4? That is the only focus they had. That was the bigger problem. As you eloquently said, they were not using for the medical, the chart purposes, medical diagnosis purposes. It is a billing. It became a focus, is a billing. So health 3.0, what is health 3.0? Why you think it is failed? Yeah, health 3.0 you explained, but what do you think of that, the reason?
Well, what I conclude in the book ChatGPT MD is that any technology that does one of two things fails. The first is if it slows doctors down, and that's the problem with the electronic health record. It didn't speed up the visit. It actually started to consume as much as half of the doctor's time, taking away from the doctor-patient relationship. So anything that slows the doctors down will be problematic. And number two, and this gets to 3.0, anything that erodes physician income. And it's not that doctors are in any way problematic. It's just human nature. So Upton Sinclair said anything that erodes a individual's income is going to be poorly understood. We could have done things like telemedicine long before COVID came along. We could have provided convenience through text messaging and secure emails, but we didn't because we didn't have the economics aligned up with the technology. So technology has to make it easier to provide care, and at least has to be neutral when it comes to income, or it's going to fail.
During the COVID, a lot of physicians use a telehealth system. Why do you think telehealth also did not succeed as people expected? What is the reason you think?
I think same thing. This telehealth is the problem, was the reimbursement. When during COVID, it was being reimbursed as at the same high level as an in-person visit, we had as much as 69% use of the technology. And as soon as that started to go away and insurers and the government stopped paying for it, we're now down under 10% if you don't include mental health services.
Dr. Pearl, a lot of physicians, I worked with a lot of physicians around the country. They have a mistrust of technology in general because things like IBM Watson promised to light out a lot of Watson system promised quite a bit. And then the EMR added more pressure to them. It created a burnout. So then now we are talking about generative AI. Why you think it is going to be different, the generative AI? Tell us a little bit, explain to us what that makes difference in fact.
Well, if I can sort of do a little bit of a side piece around technology, we use the word AI as though it's a single entity. And I think we need to take that out of our lexicon. I think we need to recognize that there are different types of AI. And I put those also into three generations. About 1980 to 2000, we had the beginning of generative AI, and it was what we call rule-based AI. Rule-based AI, it means that human beings, programmers and clinicians, take information, algorithms, what we learn in medical school, and embed it into the application. So when a question is posed, it always comes up with the answer that was put into place. The challenge is it's impossible to embed rules that are as good as the human brain. And so although it was consistently good, it never was able to be successful, either augmenting or substituting for physicians. Then we get into the second generation. It's called narrow AI. Here you take 10,000 mammograms, 5,000 of which show cancer, 5,000 of which show either no problems or benign disease. And you use deep learning and you use neural networks, multiple levels of analysis, and the application can come up with 50 or 100 different slight variations. You can put a probability factor for each. And now, suddenly, it's capable of being better than radiologists. And the data says that particularly for complex and difficult to interpret radiologic studies, it accomplishes this. This was the challenge during Watson. Watson was a narrow AI application designed around taking information from the electronic health record, being able to analyze it and come up with recommendations about treatment. The problem wasn't Watson. Watson was brilliant when it came to playing chess, where every move was well documented and accurate. The electronic health record isn't that. We don't do a very good job of coding. The same patient would be described differently by every doctor who sees that individual. And so as the expression goes, garbage in, garbage out. Yes. And so it failed to ever provide the kind of analytic tools that we need. Generative AI is completely different. Let me mention generative AI in this sense that what it is all of the information publicly available. We're talking about the entirety of the internet, all textbooks, all journal articles, and in the future we'll have downloads coming out of medical conferences. We'll actually have specific patient information, and that is used using a similar kind of methodology, deep learning and neural networks, to be able to now answer any question that comes along. And that's what's going to make it so special. A narrow AI thing, so let's say mammogram interpretation is good for mammograms. By the way, there's 400 applications that have been approved, but it can't do anything for chest x-rays or brain scans. And so it's applicable in narrow areas. Generative AI is ubiquitous and universal.
One of the things, immediate requirement for by the doctors, most of the doctors talk with me, what they say is that we need help in the workflow. Is that the generative AI can help them in the workflow area, like the everyday process, the calling back the patients and the receiving, those kind of a workflow. Can it help immediate requirement? That's what they have.
One of the most important parts for the viewers and listeners of the show is to understand that generative AI is on an exponential growth trajectory. Now, let me explain what that means. It means that the power of generative AI is doubling every year. When something doubles every year, it means that 5 years from now, it's going to be 32 times more powerful, and 10 years from now, 1,000 times more powerful. The human brain can't comprehend that. The classic study, we talked about it during COVID, was a lily pond. Each lily plant replicates every night. So 1 goes to 2. And if it takes 50 days to cover the pond, on day 43, 1% of the pond is covered. You look out there, you say, this isn't the problem. 7 days later, it's completely green. That is the trajectory we're on. What exists today in generative AI, and I use ChatGPT because it's a nice flow of words and letters, but it's equally applicable to Gemini from Google or the application called Claude, is that it is going to be increasingly powerful. We've already seen it since I started writing the book. And by the way, ChatGPT was my co-author, and I can explain more about that if listeners and viewers are interested. But since that time, it's already become far more useful and powerful sitting in play. But once it is that, and we're not talking about distant future 2050, we're talking about 3 to 5 years, it will be able to do a lot of things. From the administrative side that you're asking about, we're already seeing pretty effective tools that can listen in on doctor-patient conversations and can create a pretty effective medical record entry. 5 years ago, there were companies out there. They were okay, but not great. And now suddenly with generative AI, we're seeing the improvement. But the big difference is that now we can empower patients. We can help them make diagnoses. The thing about generative AI is you can use an application similar to ChatGPT to paint a picture in the style of Rembrandt. It'll look amazing, even though you've never had an art course. You can program a computer, even though you've never taken an IT course. You can write a song in the style of Drake, as was done, even though you don't play an instrument. And even though many clinicians don't want to believe this, it will have the ability to make diagnoses of acute problems, and maybe most importantly, allow us to manage chronic disease. And when I look at issues such as the languishing of longevity in the United States, when I look at issues such as burnout and the overload on clinicians, I think that chronic disease and its ever-growing crisis, with 1/3 of our nation either pre-diabetic or having diabetes itself, I think this tool will be the savior of the medical profession and the doctor-patient relationship. It won't undermine it. The administrative tasks are the biggest focus of today, but the biggest opportunities of tomorrow is actually being able to increase quality while making care more convenient and making medical coverage affordable.
You usually will in the future, you're referring in the future. Can you pinpoint one earliest success that we had with the ChatGPT or any generative AI? Do you see any one of them earlier the success story right now? We have
absolutely. There's dozens of them in the literature. So one example is an article in JAMA where they took patients coming into the ER, and as you well know, when you come into the ER, where you don't have a diagnosis yet, you have a bunch of symptoms and problems, and they gave all that information to both ChatGPT and to ER doctors. And ER doctors were about 83% able to make the accurate diagnosis. ChatGPT, 92%. They took information off of Reddit. These were communications between patients and clinicians. They took the same questions and gave it to ChatGPT. They took the answers from the clinicians and the answers from the technology and gave it to another group of patients and clinicians. They did not tell them which was written, what was written by a person or the application itself. And not only did they judge the material coming from ChatGPT to be 4 times more accurate and educational, but 9 times more empathetic. Study done out of Boston, where they compared ChatGPT against residents at analyzing the most complex medical problems. And once again, ChatGPT was almost twice as effective and successful at these very difficult diagnoses. The number of, I'll say, use cases. And of course, in the book, I have quite a number of anecdotes about patients. But I'll give you one specific one. Earlier this week, I was on a podcast about the book ChatGPT MD. At the end of the program, the woman who was interviewing me said, Dr. Pearl, I know that you're a skier and you're a clinician. Let me just ask you, about 2 months ago, my husband fell while skiing. His arm was extended over his head. His shoulder is still painful. He can't use that arm particularly well. What is your diagnosis? And I said, I think I know what's wrong with him, but why don't you put all the information to ChatGPT and see what you get out today? Don't follow it, but learn from it. And she texted me back a couple of days later. She said, thank you so much. Not only was the diagnosis accurate and specific, but it recommended the particular diagnostic test that was needed. And it pointed out that surgery might be required and that he should go sooner than later. And we saw the orthopedic surgeon who said if he had waited another 2 or 3 months, the torn rotator cuff might not have been able to be repaired nearly as successfully. I think these are the opportunities that are out there. And whereas maybe a year and a half ago, the technology was barely passing the step 2 examination, now it scores in the very, very top 10% and probably even better than that since the last time it was used.
Great example, Dr. Pearl. That is a great example. Let us talk about, you're talking about the patient's access to the information that they could, sometimes that patients may misdiagnose or they may take it to the wrong direction. How do you prevent that kind of a process that if the answers are not true?
Well, I want to start with 2 factors. Number one, no one should be using it today to replace the clinician. It's a starting point. It's education. You still should check with a clinician. And we're going to have to test the accuracy and reliability and see what happens across time. But I think the big problem today is that people are using, I'll say, search engines, Google, sort of Dr. Google, clicking on links. It's not that the links are bad. It's that they haven't in any way been curated or analyzed. And so you may get good information. You're often going to get general information. You may get information that is very inaccurate, that's biased, information that's quite problematic. Generative AI is going to be different than that experience. It's going to give you a very specific diagnosis. And as I said, the data now says that it can do that well better than 90%. And you have to understand that we don't do a great job often of making a diagnosis. 400,000 people in the US die annually from misdiagnoses, and another 400,000 are maimed as a consequence of that. So this opportunity to improve that information, I think, is going to be an advance. It's not going to be perfect. The question is going to be better than we have today, and then will it get better and better across time? So that's where I see that opportunity to be. I think at some point in the future, it will have a reliability that can be in place. And just last week, the company NVIDIA, they're the ones who manufacture the chips that drive these very powerful computers. They announced that they were going to have a nurse bot, AI nurse bot. This was going to be a generative AI tool, be available for $9 an hour. And they had tested it in a variety of arenas against skilled nurses. And again, consistently 10 to 20 to 30% in each category. The results were more accurate and useful than what the human gave. We're just at the dawn of this. But as I say, the sun's going to rise not decades from now, but in a matter of a couple of years.
You talk about nurse bot. That's very interesting because I came from Georgia. We have a rural areas, access to care is very. We don't have doctors. A lot of emergency rooms. I used to go and place doctors in rural Alabama, rural Georgia. So how the AI generative AI and this new kind of a nurse bots that you're talking about could help this access to care more visible to those population.
Absolutely. I mean, let's look at what happens, whether it's in a rural area of Georgia or whether it's sitting in the heart of Atlanta. It's 11 o'clock at night. You have a kid, a young child, and they have a fever of 102. What should you do? On one
Go to
hand,
Google.
you could go to the ER and you'll wait an hour or two, be surrounded by people coughing. You can wait till the morning, but it could be meningitis. How do you make that decision? You say, okay, I'll call my doctor's office. And what do you get? A recorded announcement that tells you go to the ER. Why does it say that? It's not about you and your child. It's not about the risks. It's how the doctor's able to protect him or herself. You say, you call the answering service. They say the doctor will call you back in the morning. I don't need a call back in the morning. I need information right now. That is what it can do. And if you're in a rural area and your child is at risk of meningitis, based upon, again, clinical expertise provided through an application, you better get in your car and drive. And if, on the other hand, the child appears pretty well, no neck stiffness, riding their bike around, they just happen to have a fever, you're likely better off going to bed and then talking to your doctor in the morning. It's that kind of expertise. It's beyond knowledge. In the book, I talk about everything from the printing press, which allowed books that had been solely the privilege of the incredibly wealthy to go to the middle class, leading to universities and libraries, the internet that provided far more information on the computer than the iPhone, providing that information in your pocket. And what's different about generative AI is it provides that expertise that I alluded to earlier. You're now able to make that diagnosis with a high degree of reliability and accuracy. You're able to make these clinical decisions. And maybe most importantly, if you have chronic disease, you can have wearable devices that can measure your pulse, your blood pressure, blood glucose, blood oxygen, and it will tell you how you're doing. Whether you maybe started hypertensive medication a month ago, and it should be getting better now, but it's not, so you need to change. But otherwise, you got to wait 3 or 4 months to go to the doctor's office. Or diabetes. We know we do a poor job. Less than half of the time do we control appropriately type 2 diabetes. We just need to have greater expertise for the patient. And unfortunately, physicians and nurses are just too busy today to provide that kind of hands-on assistance and monitoring. Technology can fill in that gap. And I believe that generative AI will do just that.
My late father was a doctor in a small rural village in India. That he was the only person who speaks English at the time. You can read and write English. So he is a very small 2,000 population. He was the only doctor there. And then he was a teacher, doctor, everything there in that town. You would have had such a benefit from this if he has now 90% of the rural areas are covered by mobile phones. You would have had excellent access to this kind of information. It would have been a wonderful. In fact, I remember when ectopic pregnancy woman died when I was a kid. It is kind of would have saved a lot of these saves. Do you think there is a role for generative AI, these kind of entities, that in other countries and rural areas like India and the other African continent?
There's definitely a role, and it's a role for both doctors and patients. Again, in the book ChatGPT MD, I tell the story of a superb female surgeon who was in the operating room, and she had done a very complex neck operation. And at the end of the case, when the anesthesiologist was extubating the patient, the cords were touching each other medially, risking the potentiality of a complete obstruction of the breathing process. She knew she hadn't damaged any nerves or vessels. She didn't know what was going on. Went to ChatGPT, put it into place, and immediately, within literally seconds, she had a case report of exactly the same thing happening. That for some reason, in some patients, the local anesthetic that's used migrates over bigger distances than one might imagine. In the case report, 30 minutes later, the anesthetic had worn off. The patient was fine. She observed the patient for 30 minutes in the operating room to make sure there wasn't going to be a crisis. Patient recovered completely and went home. Imagine how tough it would be to provide that care. You might have reintubated the patient, damaging the vocal cords. You might have put them in the ICU, maybe even a tracheostomy. But instead, all they needed was observation. How do you get that information? Medical knowledge is doubling every 72 days. How do we keep up with it? And even what's in the literature right now, what's happening at conferences is even more rapid than that. We have an opportunity now to provide that expertise, not just to the patient, but to the clinician. Help with those diagnoses. And I also want to say to facilitate the process. You know, in the book, I talk about what's called the Khan Academy, Khan. It's in Silicon Valley. And it's an approach to education that flips around the time order. What happens in the typical school is you go there, you get a lecture, then you go home and you do homework. This is no. We're going to give you on a computer all the information you need. You can learn it at your old speed. And when you come to class, you already know what's happening, but we now want to dive deeper with the expert, the teacher who's there. The same thing in medicine. For patients, the opportunity to understand what they might have or what they do have, what tests are going to be needed, what treatment's going to be required. That breadth of information coming from the leading textbooks and published journal articles now allows the clinician to start far down the pathway and to get to the kind of interpersonal communication that only a human can do at this particular time.
That's, you answered my question. That is my exact question. Whether we need any need for the humans, that's a human touch, human compassion, that kind of things. Is that you answered that question? What do you think? A lot of doctors say that is going to be losing that human touch, human compassion, empathy. All those things are going to be lacking in this kind of in interactive. Do you agree or disagree with that?
I think it's the opposite. I think that right now we're losing the human touch, not because doctors don't care or because they're not empathetic. They don't have the time. The average visit's 17 minutes. You can barely take a history, do a physical examination, make a diagnosis, and prescribe either an evaluation, workup, or treatment. If you had 30 minutes, you could start to ask the kinds of questions that patients want to do. You could start to have the depth of personal relationship that used to be in medicine, because we didn't have a whole lot of care we could provide, that patients desire, and actually I think that physicians desire. You know, we are healers. And I say physicians, all clinicians. Clinicians are healers. They get trained, they go to school, they get educated because they want that human-to-human connection. And I think patients are always going to want it as well. Now, when they have a minor problem, you know, they have a rash, they want to know, you know, it's poison ivy or poison oak, and what should be done and how should it be treated. They don't necessarily need to have that human-to-human connection, but make a diagnosis of cancer, chronic heart failure, some type of kidney potential problem leading to the need for dialysis or transplantation. These conversations can only be done, from my perspective, human to human. You know, I mentioned earlier that study where the messages from the computer were better than the clinician and more empathetic. It wasn't that the doctor didn't care. The doctor just didn't have the time to be able to provide the answers. The technology is able to do that for the majority of things, and then be able to acknowledge when it can't. And at that point, make sure that the clinician has the time, because maybe 20, 30% of what would have been done in the clinician's office has now been completed in the patient's home.
Just you mentioned a transplantation. I tell you, some, in those countries, particularly some countries, these middlemen go there, they charge enormous, exuberant prices to the recipient, and they don't give it to the donors. So this AI can, do you think it helps this kind of a middleman ripping off people and then not providing any care? Is actually recipients and donors, they want to maintain the privacy, but it's a big challenge in the transplantation. Do you think it helps AI in the transplantation world?
Well, certainly it can do a better evaluation, a more rapid evaluation. You know, the news has been filled with information about the failures of UNOS, the organization that does organ distribution. It all comes down to the individual clinician in the hospital, and we need a more objective system to be there. I think it'll do a lot better job of organ matching, because anytime you're talking about a huge amount of information, And I tell people the beauty of using a generative AI tool will be not only will it have all your information about your diseases, your family history, and medications, it will have your entire genetic sequencing. And that's not anything that a human brain is capable of doing. There's just way too much information sitting there. We see it in cancer work right now. And I think similarly, we need to understand better information about transplantation. We actually probably need to be able to have a technology that's able to analyze it and find rejection earlier so we can treat it with less medication, fewer side effects. So I think it can help a lot. And in most situations, replace the middleman. I think what you're describing there really is a black market on organs. And the good part is that the technology is not going to be greedy. It's going to be simply a servant of the people, and it'll be up to the humans about how best to use it.
Dr. Pearl, this is exponential, that growth of this AI, that it is going to be so, it can go out of control, then how our political system or economic system, financial, legal system, can they match this exponential growth? How do you control that process? How do you match that kind of a systems into we are prepared for the humans can be prepared for that kind of a exponential growth?
Well, there's really two parts to the question you're asking. The first one is you can't control it. We're talking about these are the revolutions in history, the Industrial Revolution. It wasn't you can control it, you can make sure that you're the master of it rather than being the victim thereof. We had revolutions in the United States that created the split away from England. India breaking away from the British Empire was certainly a revolution. Revolutions have a life to their own, and once the spark is lit, usually the fire follows. And I think that's what's going to happen here. The idea that somehow this will stay the purview of the clinician, that's not going to happen. If it's not led by clinicians, what we're going to see is that someone else, whether it's the retail giants, whether it's private equity, is going to come in and use this technology because patients want it. And so we have to be the ones, I believe, to lead the way. There is an existential question that you're raising, and it's far bigger than the use of generative AI in medicine. This is the whole question of what happens when computers get so powerful that they can enslave people. There's certainly a massive amount of science fiction that's been written about this across time, and I don't have a great answer for you about how to prevent it. But I want to point out something else, which is that we often create our own existential crises. Look at climate. At the rate things are going, half of the world is not going to be livable. And what's going to happen as a consequence of that? And I believe that if it's going to be solved, there's a good chance that tools like generative AI will be instrumental in that. So is there a risk in using the technology? Yes. Is there a risk in not using the technology? Yes. And so what we have to do is hope that we can drive the positive sides faster and better than the negative and potentially very threatening outcomes that can result.
Dr. Pearl, that there is some of the things that the people are talking about the central intelligence. The intelligence is not distributed here. Is all there is some people are managing this intelligence, how to manage, and that's going to be a problem. The people complain that's going to be a threat in the future. Is centralized intelligence part of it? What do you think that? Well, some people are complaining about that we need a distributed intelligence. It is more, but you said that narrow intelligence is a dangerous. So explain to us a little bit about that. I was reading.
AGI, which is the general intelligence, is being talked about. I don't know that the terms that we've used for the past decade apply to generative AI as well as they did before, because it's almost impossible to measure the abilities of this tool. They're so dependent upon simply the amount of information you put in there. The more information you put in, the better it becomes. There's a learning curve that has to happen. It's what's called prompts. If you just say, tell me about diabetes, you'll get a lot of information. But if you say, I'm a patient with diabetes, I'm taking insulin, I have a history of heart problems, and 3 other factors, it will give you very specific information to yourself. We have to train everyone around that. And you're really raising another question, which is what's called equity. Right now, we do a terrible job. There's just data coming out of the Commonwealth Fund today about the dramatically higher, many times higher mortality in certain groups like Black patients and Latino patients compared to white and Asian patients. And if you pull back the covers and look at it, it's really a socioeconomic driver. And we know that in poor parts of the country, outcomes are much worse than in wealthier parts. And within those communities, the poor individuals in the communities, the ones socioeconomically challenged, have poor outcomes. The question you're really raising is, will generative AI increase that gap or shrink the gap? And I'm optimistic that it can shrink the gap because, as you mentioned earlier, if you're in rural Georgia, which is not a question of the socioeconomics, and you can't get access to care, you have nothing. In Atlanta, you got a lot of options. But generative AI may increase the care in Atlanta 10%, but it'll increase the care in the rural areas 50 or 75%. And families that can't afford or can't take the time to miss work in order to get medical advice and information, that they don't have the time to have their chronic diseases evaluated and better managed. This will create the time for them, or at least give them the opportunity to access it as a means of doing so in a very time-efficient kind of way. So I have a certain optimism. I also recognize that our society is so unequal right now that this tool could also be continued in that process. I don't think it's going to make things worse, but it may not close the gap as much as I believe it should.
So you see, talking about bias, let's talk about that a little bit. That, as you know, that pulse oximeter was, for the black patients. It was during the COVID. It came out of I don't know whether the artificial intelligence found out about that, or the actual the doctors realized that. But this kind of a big gap of bias. If you depend on AI, if it has a bias, how do we know? How do we check that bias itself? Because we trust it so much. How do the checks and balances we can adopt for the AI?
That is such an important question because there is so much bias, and it's probably implicit bias. It's not active discrimination. It's just that we ignore those things that we perceive as not being particularly problematic for ourselves. Again, in the book, I talk about the classic experience. This was Optum, which is a subdivision of United Healthcare.
Yeah.
And they wanted to do a good thing. They want to identify I forget how many patients, 2,000 patients, that they wanted to give more resources to because they thought they were at great risk of having complications from chronic disease. And they used an AI application. In this case, it was a narrow AI application, but it could have been a generative AI application. And when they then found the list that was created and compared it to independent human analysis on a case-by-case basis, what they saw is that rather than 40-some-odd% of patients who should have been Black individuals chosen, only 15 or 20% were. And the headline screamed, AI is biased. AI is not biased. What happened? The application looked at the dollars that we spend, and it noted the fact that Black patients with exactly the same medical problems receive $1,800 less care. And it made the assumption, a logical assumption, that the more money that's spent in healthcare, the sicker you must be. It failed to recognize that we don't do a good job during COVID, even though Black patients had a higher mortality rate. When there was a shortage of testing kits, we tested them half as often as white patients. We know that they're offered major heart procedures when they have heart failure less often than white patients with the exact same degree of severity of disease. The problem is not the technology. The problem is the individuals who are providing the care having implicit bias and not knowing it. And I'm hopeful, this again, I don't know, but I'm hopeful that generative AI will be able to spot that bias. They'll be able to look at the data on a continual basis. And what we know is that Black patients receive 30% less pain medication after the same procedure as white patients. It will point out the fact that it's lower. It won't tell you it should be higher, but it'll make you think, why am I prescribing less medication? Maybe it's because you have a fear about some addiction problem. Maybe it's because they have an associated disease, but maybe it's because you and I and everyone else have this implicit bias. So bias is a big issue. It's a problem in society overall, and we'll have to address it when it comes to broader use of artificial intelligence.
In your ChatGPT book, that what you did exactly other way around, in a sense, a little bit about the technology alone is not can't solve the problem. You give example of Ferrari car, and then they say we need a board leadership. I loved your mistreated book. I met you during the mistreated Commonwealth Club. At the time I read that, that's what the mistreated book was. You're always propagating this. You need a bold leadership. How come? Why we have such a leaders in the John F. Kennedy and people like you? Where it is that leaders are missing in nowadays in healthcare, and how do we find them?
I'm very glad you're raising this issue. The book has 5 parts. The first 3 are about the technology and its application for acute disease, chronic disease, hospitals at home, a variety of areas. Part 4 is about the issues we just discussed: privacy, security, misinformation, bias. Part 5, those are all about leadership. And let's go back to the healthcare 2.0, 3.0 that you raised earlier in this conversation. I said there were 2 reasons why technology does not get adopted. One was it slows doctors down. And so if the result of using generative AI is going to be 20% more work for doctors rather than 20% less, it's not going to get used. So we have to make sure we use it in ways that diminish the demands on the doctor every day, free up time to be able to devote to the doctor-patient relationship. But the second thing I said is that if it erodes income, and the reason why I'm so bullish about generative AI is that I think it's the first tool we have with a high potentiality to improve health, to avoid chronic disease, to avoid the complications, heart attacks, stroke, cancer. We've done a lot of work in Kaiser Permanente using technology because it's an integrated medical group. And using the best approaches with people collaborating and cooperating, we reduced heart attacks and strokes and cancer, specific cancers, by 30 to 40%. Imagine if across the US today, we were able to eliminate 30%, 40% heart attacks, strokes, renal failure, infection, cancer. Costs would plummet. But what does plummeting costs mean? The people providing the care are going to have less income, and that's not going to go over well. So what do we need to do? We need to transition from the transactional fee-for-service system. The more you do, the more you get paid. If you do twice as much work, even though you could have solved it with half as much time, you get paid twice as much, to something else, which is going to be a form of value-based care, prepayment. I like the word capitation, a single payment to a group of doctors taking care of a population of patients. This is the opportunity. And unless we're able to bundle together generative AI with a transformed, with an evolved primary payment mechanism, reimbursement methodology, it's not going to work. And this is where I think leadership will be so crucial to be able to navigate that very difficult path. So to the question that you posed, why do we have I'll say a dearth today of effective leadership? I think it's because the system is broken. And I think that everyone has figured out that it's a lot easier to be, as you said earlier, a middleman type mentality. It's a lot easier to figure out how to raise the volume, how to consolidate hospitals and raise prices than it is to figure out how we can make care more efficient. You know the fact that I've written 2 previous books. They were Washington Post bestsellers and Kirkus Star winners, Mistreated and Uncaring. And in those books, I talked a lot about what I thought needed to happen. We need to move from fee-for-service to capitation, fragmentation to integration with collaboration. We need to use modern technology. And what I realize now is that the problem wasn't that people didn't understand it or didn't even agree with it. It's that we didn't have the tool to translate that vision into reality in a way that didn't slow doctors down and didn't cut their income. That's where I think we are right now with generative AI. And so I'm hoping as this technology becomes more ubiquitous, as people find its power to be so effective, that leaders will come out. But I do offer in that last part what I call my A to G model, the ways that we have the ability for leaders to lead better. You note in your headline for this show, I talk about the need for leaders to understand the heart and the brain and the spine. They need to be able to provide the brain the logical explanations for change, but they also need to touch people's heart, to touch their emotion, to touch the mission and purpose that drove doctors and clinicians and nurses to be able to go into medicine in the first place. And then they need the spine, because I don't care what transformation you're talking about. There's always going to be resistance. There's always going to be reluctance. And the leader has to have that spine to keep the process moving forward.
Eloquently said. I want to ask you about the leadership that you're saying. So, doctors are not only they treat patients, but they're advocates for the patient's health and the nation's overall health of the nation. So, how the advocacy of the entire country to play, and how they can generate AI or whatever the new models coming up, how can they help the increase the advocacy of the patients? Right now, patients don't trust the healthcare system, don't trust sometimes doctors. That's a big challenge they have. How can we do the advocacy part much more effective in doing these things, Dr. Perel?
Again, you're spot on, but you have to ask, why is advocacy necessary? What's the problem we're trying to address? That's why I have that subtitle, How AI Empowered Patients and Doctors Can Take Back Control. Right now, healthcare is being driven by the insurance industry. And, a lot of people want to vilify health plan leaders. I don't vilify them. They have a tough problem. What we're seeing right now is that the cost of healthcare is rising. The projection by the federal government is that healthcare is going to increase in cost by $3 trillion a year by 2031. That's only 7 years away. So if you're a health insurance leader and you go to the businesses that buy your insurance, they say, we can't afford that kind of increase, a 75% increase in cost for the healthcare we provide. What are you going to do? You're going to come back and you're going to ratchet down. You put your thumb on the delivery of care. You have no choice but to try to ration and limit that care. And now the doctor, as you say, on behalf of the patient, fights back. And so we spend a massive amount of time in prior authorization and in letters back and forth, adding no value at all. And I think that advocacy is not going to work. I don't think the clinicians providing the care will have enough political or economic clout to do so. What I think is that if they leave the process of transformation, all of a sudden you don't even need insurance companies, because you can work directly with the businesses to be able to get the capitated payment in order to be able to provide the care to patients with higher quality, greater convenience, and lower cost.
That is exactly my question. Next question I want to follow up. We need to, if you are saying that $3 trillion increase, a big increase, then we have to question the first principles. What are the first principles? Or do we need insurance actually? Is there any alternative systems, like particularly these quantum computers coming in with the AGI, or the generative AI, combine them with the quantum computers, can probably produce that kind of alternative solution? What do you think, Dr. Pearl?
I'm a big believer that it's the triad. It's going to be the dedicated and skilled clinician working with the empowered patient, using generative AI as the tool to be able to achieve these outcomes in less time, avoiding things like redundant care, making sure that the right diagnosis is made the first time, that medical errors can be avoided. I can go down a litany of opportunities that exist. We know that they're there, and yet we have not had the ability to accomplish what we needed, which is to eliminate the inefficiencies and the redundancies, to be able to make sure that the care we provide is the safest. And that's where I believe that we are today.
Thank you, Doctor. Thank you, Dr. Perel. This podcast is, sponsored by Lucidac, Lucidac.com is a remote patient monitoring. What do you think of remote patient monitoring care going to the home? It helps. What do you have any final comment on that?
I definitely do. I'm a big believer that we should be making care continuous. Patients have chronic disease. We know that over 2/3 of Medicare patients in the United States, patients over age 65, have 2 or more chronic diseases. We have remarkable monitors. They're very accurate. The problem we have is the information that's generated doesn't have the impact it should have. Why is that? Because the patient has difficulty interpreting it. The clinician is too busy to receive all that information, doesn't want the electronic health record being cluttered up. We need this intermediary. Could it be done by nurses? Yeah, but that's very expensive. What is possible is to do it with the technology that exists right now. You know, it's been probably 8 or 10 years that I've been pushing Apple and its CEO to be able to include this in all the monitoring that's done. Don't send all the information on heart rhythms to a call center someplace. Tell the patient how they're doing. And don't just diagnose new arrhythmias. Tell patients who have what we know to atrial fibrillation, whether they're under good control or not. And it hasn't happened. I think we're now entering into an era when it will. I mentioned earlier the NVIDIA ability. So yes, I'm a big believer of monitoring. I think hospital at home, 30% of patients in hospitals in the US today could be better managed at home without delirium from being kept up all night by lights and noise, by being surrounded by loved ones, by being given good food. But why don't we do it? Because we never had the monitors. We've had the monitors, but we haven't had the means of being able to know how patients were doing, offer that data. Yeah, I'm a big believer and supporter of monitoring for patients, for homes, for minor problems, for major problems, for chronic disease problems. We have the technology. Now we need the leadership to put the system in place.
Dr. Perel, is a total privilege. You know, I read your story about your grandfather and father. It is a really, I kind of related to that. You know, even though I grew up in India, that stories are similar. You grew up in a different world, but the story is extremely similar with the same background, similar backgrounds, the trials and triumphs of that whole family. It is a fascinating. Your book is a treat for anyone, that not only it gives you a wealth of information, it is just heart moving stories that you tell in this process. It is all total privilege, Dr. Perel. Thank you for I'm totally honored and privileged to have you on the podcast today. Thank you so much.
And if your audience wants more information, they go to my website, robertperelmd.com. Please buy the book with all the profits going to Doctors Without Borders. It's going to take a lot of us together to change medicine, but we can do it. And we can improve human life and human health. Together, we can make a huge difference for the world. Thank you for having me today.
Thank you, sir. Thank you. Good night.
Are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it